Right. And a very good morning to everyone. So I will present my presentation is about acute pain service and pain management in the ICU. Um, okay, so to start with, my topic will start to emphasize and to improve the knowledge of the pain management is either perioperative period, traumatic cases, and medical cases. Okay, and then secondly, the objective of my presentation today to provide the safe practice and efficacy of analgesia to the patients, and the thirdly is to educate and increase awareness among vast options of analgesic methods for various surgeries, and also to avoid and detect, ultimately manage a side effect and unwanted complications. I'm sorry, yeah. All right. So the principle of management in the of the pain control and in the acute pain services. First of all, we must know that it is a multidisciplinary responsibility. Okay, not in just involved with the anesthesia team, it also belongs to the primary team, either is surgical, orthopedics, or medical teams, and also involved with the physiotherapy, occupational therapy, and also pharmacies. And detailed assessment and reassessment, and then the pain control and documentation is a very crucial in the pain management. And we must tailor our treatment and individualize according to the patient from the beginning of the treatment. And our aim is to reduce pain at an acceptable range and not focusing to eliminate the pain completely. And another is to adequate and provide the frequent monitoring for the patient. And another is we want to aim is to restore the function of the patient and then continuous monitoring subsequently. Okay, so further is about the definition of pain. Okay, so previously that we have been taught that from the 1971, the definition of pain is an unpleasant sensory and emotional experience associated with the actual or potential tissue damage or described in terms of such damage. This is from the 1979 by the IASP, International Association for the Study of Pain. However, in 2020, the IASP already revised the definition of pain to the unpleasant sensory and emotional experience associated with or that associated with or actual potential tissue damage. Okay, it's just a matter of a wording. They just add another resembling that associated with or actual or potential tissue damage. Besides this revised definition, they also put in some points on the definition of pain. First, pain is always a personal experience by the patient. Okay, it can be influenced by the biological, psychological, and social factors. Number two, is a pain and nociceptions are different phenomena. Okay, pain cannot be inferred solely from the activity in sensory neurons. So this is important in the chronic pain. And pain is a life experience, and individuals learn the concept of pain. The fourth one, a person's report of an experience as pain should be respected. Okay. Number five, pain usually serve as an adaptive roles. It may have adverse effect on function and social and psychological well-being. And another is a verbal description is only one of the several behavior to express the pain. Inability to communicate does not negate the possibility that a human or non-human animal experience the pain. So this is to give a thorough and more well described about the pain, so that we can use it for our daily practice. Okay, so the pain, it can be divided into the acute and chronic pain. Okay, so the pain is from the acute pain is defined by the pain of the recent onset, and it's probably a limited durations. So it can be lasted about 2 to 3 months. And whereas the chronic pain is commonly persists beyond the time of the healing process and frequently may not be identified causes. And usually is argumentative about the duration of chronic pain, but some we describe as a chronic pain is more than 3 months. Okay, usually the acute pains, by the time of healing process, the acute pain is gone. Okay, but the acute pain still can persist and become the chronic pain, or the chronic pain can appears after insidious onset. Example is a chronic pain. Okay, so the physiology of the acute pain. Okay, so we are the humans, are the survivor, that we are born with the ability to detect nauseous and potentially tissue damaging stimuli, the nociceptions. The nociceptors are the receptors to detect the nauseous stimuli. So the pain stimuli can be chemical, mechanical, thermal, or mixed, that will be transduced into the electrical signal subsequently transmitted by the nerve fiber to the spinal cord and the brain. Within the pain pathway at the level of spinal cord and further upward, we can divide the pathway into the first order neurons, second order neurons, and third order neurons. Okay, these are the example of the pain receptors. As we can know, the pain receptor can be divided into the ionotropic or metabotropic. So actually in our body we have a very plenty and numerous receptor. Okay, it's either from TRP as a transient receptor potential, acid sensing, glutamate, purine, serotonin, nicotinic for the ionotropic, whereas in the metabotropic is in the opioids that we know of, mu, delta, kappa, and nociceptics receptor, and proteinase, tachykinin, cannabinoid, bradykinin, serotonin, histamine, prostanoids, and also metabotropic glutamate. And this receptor, after after the receptor detect the painful stimuli, so it can be then it transduced to the electrical signal, which can be transmitted by the mostly the pain. The pain nerve fiber are alpha theta and CF nerve fiber. Okay, so the next one is the transmissions of the pain stimuli. Okay, we can see from the right, there is an activation of the pain receptor by the after the pain receptor detect the nauseous stimuli. Okay, so then from this, it be transduced to the electrical signal, then can be transmitted by the afferent nerve fiber as a first order neuron. As I mentioned earlier, it can be transmitted by the A delta and C nerve fiber. And this nerve fiber will end in the dorsal horn. And then the second order neuron started at the spinal cord level, is either spinal thalamic or spinal reticular tract, and ascend to the thalamus, where the thalamus present the third order neurons. So the difference between first, second, and third order neuron is by the location of the cell body. Okay, the first order neuron cell body at the dorsal horn, where the second order neuron is in the spinal cord level, and the third order neuron in the thalamus. Okay, this is the ascending pathway on the left side of the slide. ascending pathway of the pain. Um, so I mentioned earlier, so this is the location that usually our analgesia working. As we can see, the peripheral side, usually the NSAID and opioids, and the nerve conduction, it can be blocked by our local anesthetic at the spinal cord level. Usually is our opioid, clonidine, tricyclic antidepressant, and also NSAID, but some also present is opioid. Whereas the descending pathway, and this is we call the modulation or the pain inhibitory pathway, mostly it responsible for the chronic pain. It is involved with our opioids, clonidine, nitrous oxide, and also tricyclic antidepressants. Okay, the impact and then the physiological changes of the pain. Why so important? We need to control the pain because the pain itself can cause a lot of physiological changes to our patients. Okay, it can cause the metabolic or immunological and also endocrine response to the injury. We can see in endocrine, it increase the catabolic hormones. Okay, increase the ACTH, cortisol, ADH, growth hormone, catecholamines, angiotensin 2, aldosterone, and glucagon. And it reduce the anabolic hormone, reduce testosterone, and in the immune system, patient prone to develop immunosuppressed state. Whereas in the metabolic component, it can, for the carbohydrate metabolism, it can develop hyperglycemia, glucose intolerance, increase the insulin resistance. Whereas in the protein, patient develop muscle protein catabolism, increase synthesis of acute phase protein, and also increase the lipolysis and oxygenation. And also in the water and electrolyte flux, okay, it can cause further the water retention and also sodium retention, and increase the excretion of the potassium, reduce the functional extracellular fluid with shift to intracellular fluid, and can cause more of the tissue edema. Okay, so impact of the poorly controlled pain. So it increase of the myocardial oxygen demand and increase the sympathetic stimulation, increase the heart rate, increase the blood pressure. Okay, so this is a risk of the myocardial ischemia, especially the pre-existing cardiac disease. And also for the respiratory system, it can lead to widespread pulmonary changes, inability to cough, hence atelectasis, impaired VQ mismatch, hypoxemia, increased post-operative pulmonary complication occur. In the GI system, it increase gastric and intestinal secretion, decrease the gut mortality, prone to develop ileus, nausea and vomiting, increase the urinary retention for the urinary system. From the CNS, patient can develop depression, anxiety, and insomnia. In the long-term run, this acute pain can progress to the chronic pain. So further, when we know more about the physiology, so now further we need to assess the patient. So what's the best tool for the patient? What's the best tool for us to assess the pain of the patient? It must be standardized from one patient so that we can deliver the message, from one healthcare worker to another healthcare worker. So that's the reason why we need to have a very good pain assessment tool. Okay, because the aim is to recognize and assess pain, okay, so that the proper management can be carried out. Pain is individual, internal, and subjective experience and description from the patient. So the important is to reduce subjectivity, and it can provide us objectivity, just like our blood pressure, heart rate, respiratory rate, saturation of oxygens, okay? and it can be divided. Okay, our tools can be divided into either self-reporting, which is a simple, quick, and easily carried out by the healthcare provider, and it must be easily understood by the patient. And this self-reporting usually unidimensional, whereas in the observational or behavioral tool, it is multidimensional. It's combination of the pain intensity, quality, affect the interference with functioning, quality of pain. This is commonly used for the young children and mentally challenged adult. Example, dementia patients. Okay, so when we plug the patients, we need to have a system, okay, and so that our documentation much proper, so that we can manage the patient properly ultimately. So usually I advise for my medical officer to put by this mnemonic of Socrates, okay, where the site of the pain, onset of the pain, character of the pain, whether the pain is radiated to anywhere, and association whether the pain involved with the nausea and vomiting, sweating, okay, and then the time course, whether the patient start to move on the right or the left positions, exacerbating factor, okay, and also the severity of the pain. Okay, this is another pain history that we can get from the patient. The site of the pain, circumstances associated with the pain onset, whether included the detail of the trauma or surgical procedure, is a character of pain. Okay, associated the symptoms, effect of pain on the activities and sleep, treatments, relevant medical history, and also the factor influencing the patient's symptomatic treatments. Okay, this is more towards of the difficult patient or the chronic patient. Okay, it involves the belief of the patient, knowledge and expectation and preference for the pain management. Okay, and the reduction of the pain for the patient satisfaction and typical coping response for the stress or pain, and the family expectation and belief about the pain. Okay, so about the self-reporting, so it is still remain the gold standard. Okay, it's unidimensional, as I mentioned earlier, and there is a visual analog scale, and it can be the numerical rating scale, verbal descriptor scale, Warm-Becker scale, Faces scale, and MOH pain scale. Usually it's a combined VAS and NRS. Okay, so this is the top one is a visual analog scale that we usually frequently see during our pain rounds, and a Warm-Becker Faces pain rating scale. And on the right side, also the pain Faces scale that we always show to the patient. And this is our KKM MOH pain scale. Usually we incorporate numerating and NRS and also the Faces scale. And how about the self-report? Also, we have a multi-dimensional McGill pain questionnaire. Okay, it is a lot more criteria that involve, as I mentioned earlier. And also there is a flat pain scale, which has a few components of the scale. The first one is face. Okay, the second one is legs. Okay, activity for the A, C for the cry, C for the consolidity. Okay, usually each category is scored on the 0 to 2 scale. Okay, which result in a total score of from 0 up to 10. Usually 0 is a relaxed and comfortable, 1 to 3 is a mild, 4 to 6 is moderate pain, more than 6, 7 to 10 is a very severe pain. Okay, another is how about for the patient with a cognitively impaired patient, example patient who are demented. Okay, so we can do by the assess the patient by the Abbey pain scale, which comprises of vocalization, facial expression, change in the body language, behavioral changes, physiological changes, physical changes. Okay, usually we see this usually in the geriatric patient in the geriatric wards from the medical patients. Okay, usually another pain scale that we can use is pain assessment in advanced dementia patient by the PINET scale. Also, it can have by the criteria from the breathing pattern, vocalization, facial expression, body language, and consolability. Okay, the score is up to 10 also. 1 to 3 is by the mild pain. 4 to 6 is moderate pain. 7 to 10 is a severe pain. Okay, so the MOH guideline suggests us to use for the adults either NRS and VAS, or we can use both. For the age of 1 month to 3 years old, we use a flat scale. 3 to 7 years old faces pain scale. More than 7, we can also use MOH pain scale. So, but for the pediatric patient, again, they have a very quite a variant developmental delay, neurological developmental delay. So we have to tailor from patient to the patient and individualize our assessment. Okay, so to provide this a safe and effective acute pain management, so the healthcare worker must have a very good and broad knowledge in the pain management. So need also to educate the patient about pain assessment, treatment, and expectation, and also possible adverse event. So we have to provide a more structured teaching and education of the patient, starting from the pre-op, either the web-based video reading material or at least effective verbal techniques. And again, it depends on the social education status of the patient. And APS team and nursing team also should familiar with advanced analgesic technique, example PCA, epidural, continuous plain block infusion to improve and to provide the better care for the patient. And it helps to have a standardized guideline and protocol and the monitoring requirement, choices of equipment, and respond to the inadequate or excessive analgesic doses or other complication, so that we have a very consistent practice to provide a safe and effective pain management. Okay, why we need to have all this? Because of the benefit of a good pain control to provide the better pain relief, lower incidence of the adverse event, to have a lower post-operative morbidity and mortality, to manage the to reduce the incidence of persistent pain after the surgery, and ultimately the cost effectiveness. So how about the pain management? Okay, so we go by I will emphasize first, it's just not all about the pharmacotherapy. So we should start also by the non-pharmacological approaches. So it involves the multidisciplinary obligation. So we can see on the right side of the slide is a biopsychological factor. So it involves a lot of mini factors that we neglect during our pain rounds. Okay, the first of all, from the biological, we can provide the drugs, our pharmacotherapy. We can provide the electrical nerve stimulation by the nerve block, by the radiofrequency ablation, by the physiotherapies, and by the psychological. And we explain and reassure the patient, educate the patient, supportive counseling, cognitive behavioral therapy, okay, the social therapy, at the workplace, insurance compensation, disability fees, skepticism, and stigmatism, okay? And these are psycho and social factor usually mainly involved in the chronic pain management. How about the physical therapy? Usually is the simple one is rest, ice, compression, and elevate. Usually we can see in the orthopedic surgery, especially arthroplasty. Acupuncture is shows and proven in better for the post-operative anesthesia, and it can also the acupuncture also can be used as a sole anesthesia in thyroid surgery, and also it can reduce post-operative nausea and vomiting. Massage, heat and cold therapy, okay, chiropractic, and also transcutaneous electrical nerve stimulation. Okay, the good thing about the drug-free, about TENS, okay, transcutaneous electrical nerve stimulation is a drug-free method. Okay, has a fewer side effect as compared to our opioids, our NSAIDs, and the concept used is a gate control theory. Okay, so usually the pain transmit by the C fiber, but then we give our electrical stimulation but at the A beta fiber, so we block at the spinal cord level. Hence, we block the transmission of pain by the C fiber and totally block the ascending pathway. However, this is less effective in acute pain management as compared to the chronic pain. It only shows improvement in the primary dysmenorrhea so far for the acute pain. Okay. So this is the advantage of the biopsychosocial play out in the pain care. Okay, it can patient can faster return to work, reduce a pain reduction, and ultimately, it give a better medical cost saving. How about our pharmacotherapy? Again, our pharmacotherapy, the keyword is we always go by the multi-modal and balanced approach. Okay, what's the difference between the preemptive and preventive analgesia? So preemptive, usually we start pre-operatively, pre-insult, or the pre-surgery, the timing. How about the preventive? Usually we give to the patient post-operatively, or sometimes we use intraoperatively to the patient. So it can be our pharmacotherapy, or it can be the placebo or no treatment at all to the patients. All right. So how about the pharmacotherapy? We can provide it by the multiple routes of administration. Okay. First, we can give to the oral. Second, we can give to the rectal by suppository, by the intravenous, intermittent infusion, or patient control analgesia. Okay, intramuscular, subcutaneous by inhalation. As example is nitrous oxide, transdermal, okay, by our fentanyl patch, transmucosal, okay, sublingual. It can be given by the central neuroaxial, epidural, or intrathecal. Okay, the plain block, paravertebral block, tight block, serratus plain block, you name it, or it can be by the intra-articular. Okay, this is usually given by the surgeons. Okay, so for the pharmacotherapy, we can divide it into by the opioid base or non-opioid base. So we can classify our opioid base by the strong, weak, or partial. Okay, our strong opioid is a morphine, fentanyl, amfentanil, remifentanil, oxycodone, and pethidine. Whereas in the weak opioid, this can be divided into dihydrocodone, okay, DF118, tramadol, pantoprazole, and partial is nalbuphine, buprenorphine are the example of the partial agonist. And antagonist is naloxone. Okay, how about non-opioid based? Okay, it can be classified into the several groups. So the first one is a COX-3 inhibitor, is a paracetamol. Non-selective is COX inhibitor is a ibuprofen, okay, naproxen, meloxicam, ketorolac, and so on. Selective COX inhibitor, celecoxib, acoxia, and paracoxib. Okay, local anesthetic agents. Example here, I put lidocaine, ropivacaine, and bupivacaine. Inhalation agent, nitrous oxide, methoxyfluorine, NMDA receptor antagonist, ketamine, magnesium sulfate, alpha-2 agonist, okay, clonidine, dexmedetomidine, corticosteroid, dexamethasone, alpha-2 delta, calcium channel blocker, or anticonvulsants is a gabapentin, pregabalin, or bone modifying agents, especially for the acute bone pain in the cancer patient, is a calcitonin or bisphosphonates. Okay, so for the opioids, okay, so we have to know more about the pharmacokinetic and pharmacodynamic, how the mechanism of action, so that we understand and we know what to anticipate when we start opioid therapy for the patient. Okay, so as we know, the opioid receptors can be divided into mu1, mu2, kappa, and delta receptor. Okay, we can see usually our synthetic opioids usually acts on the mu receptor, in which either supraspinal or spinal level. However, they also have a slight actions on the kappa and also delta delta receptor of the opioid receptor. Okay, so hence you can see the patient develop of the sedation, physical dependence, constipation, urinary retention, okay, meiosis, if we go higher doses of opioids. Okay, so our opioids drugs can be given by the several routes, okay, of administrations. Okay, example, morphine we can give by the parenteral and central neuroaxial, or it can be given by the oral. Fentanyl can be given the parenteral, central neuroaxial, transmucosal, or transcutaneous by the we can give by the lollipop. Fentanyl for the pediatric patient or for the cancer patients. Oxycodone can give by the parenteral or oral. Remifentanil can be given by the parenteral only, cannot be given by the central neuroaxial because it also have a minimal action on the GABA channel. Okay, from the pharmacodynamic of the opioid, it can develop euphoria, sedation, meiosis, reduced cough reflex, nausea, vomiting. Okay, from the CNS, it can develop euphoric. CVS can develop hypotension, and also due to the decrease the systemic vascular resistance by the respiratory system, it can develop bronchoconstriction. It can cause respiratory depression due to the central acting. GI increase the reflex of the Oddi sphincter. Okay, can cause a constipation, can cause urinary retention, increase the ADH effect, and also can cause a pruritus. Again, for the options of the when to start opioid therapy, usually at the moderate pains, okay, by the WHO ladder therapies, okay, pharmacotherapy. So usually the mild to the moderate pain, usually the pharmacotherapy started by the primary team. So after they have a problem to manage the patient, Okay, by starting the with opioid, usually the tramadol, so usually they refer to us, our APS team, to start the opioids therapy. But then again, we as the APS team need to check the right dose, the right pharmacotherapy that has been initiated by the primary team. Okay, this is another example of the analgesic ladder for the acute pain management. Okay, so usually the mild, we started PCM or COX-2 inhibitor. For the moderate, our team will start the tramadol. For the severe pain, so we give started the opioid therapies, either morphine, IV or oral, or it can be PCA, okay, or subcutaneous, and so on. Okay, so I will to emphasize about the patient control analgesia. So it's a programmable infusion pump. So our PCA actually, we frequently see PCA given by the intravenous. But when you go to the pain center, like example, in HKL or it can be in Selayang Hospital, they can give the PCA by the subcutaneous. Okay, can be given by the transdermal. Okay, some center we use a PCA for the epidural called a PCA, or it can be given by the peripheral nerve catheter. Okay, why we provide this option? Because it's a safer and it's a more efficient technique compared to the infusion. And the component is usually our pump has a microcomputer program, syringe pump, and device for the activation by the patient, lock and keys, and delivery system, and the display window and alarm. It must have a dedicated IV line with the anti-reflux valve. Usually the program must have the PCA mode, is either continuous mode, okay, or it can be both. Drug concentration must be correct. It's either morphine or fentanyl, depends on the center. Okay, it can be varying doses and concentration at a different center. So it has a loading dose, a polar dose, continuous infusion or background infusion, and also it has a lockout interval. It depends also, it's not all patient we put a 5 minute. Some center we have a 10 minutes, 50 minutes, or even up to the 20 minutes. So because we can provide a better, safe profile of the PCA to the patient. Okay, so the another is we usually put the 4 hourly limit. Why we put the 4 hourly limit? Because we need to have a frequent monitoring by the nursing team in the ward or by our APS team also. Okay, so the reason why I put this graph, because okay, we need to achieve at the anesthesia level before we start our PCA. So usually when we see the patient in recovery, usually the patient have the pain. So we need to provide and we need to achieve the analgesic drug concentration first before we continue with the PCA. So hence we need to give a bolus dose for the patients is about 2-3 mg of the morphine as example or ocinol, depending on the patient's conditions. So monitoring on the PCA, okay, it must have a respiratory rate, blood pressure, pulse rate, pain score, and sedation score. So here I use a sedation score by the MOH, so 0 to 4. So the 4 is severely sedated when your patient is sleeping. Okay, and we need to document all the above finding during our APS review so that our next reviewing team can know what the patient condition prior to that. So the next is about our LA. So our LA usually mainly acts on the central and peripheral nerve pathway. It's either peripheral nerve, A delta or C fibers, or at the spinal cord level. And usually the voltage gated sodium channel receptor. Okay, so these are the dose of the local anesthetic agent. Usually what we use is a chiroquine or levobuprofen. It's a 2 mg per kg. And ropivacaine is a 3 mg per kg. Lidocaine is a 3 mg per kg, but If you use adrenaline, so it's up to the 7 mg per kg. However, for the airway topicalization, we can go up to the 9 mg per kg. So we need to know these doses by the heart, okay, by heart, because we are the SDMO, we use frequently all these drugs because widely used in our daily practice, either for the spinal, epidural, peripheral nerve block, infiltration, intravenous regional block for Pierce block, intracavity infusion, surface anesthesia, topical, or it can be used as an antiarrhythmic. And again, this is a example of the epidural dose bolus dosing. Okay, depending on what is our aim, is either analgesia or anesthesia. Okay, so epidural cocktail. So depend on the individual hospital guideline. You can use as a 0.1 chirocaine with the fentanyl 2 microgram, or you can use a ropivacaine, either 0.1 to 0.2% ropivacaine. So depending on the individual local hospital protocol. Okay, rate of infusion, lumbar infusion can use 6 to 12 mils per hour, or thoracic can go up to 8 mils per hour. So we can add adjuvant, example opioids, clonidine, sodium bicarbonate, or ketamine. So far, I've been using the adjuvant for the epidural cocktail is clonidine. The dose is about 1 mic per kilo. Okay, this is our example of our epidural block. Epidural APS form. So here has a Bromage score there. So we need to document also the Bromage score. And by the 0, 1, 2, 3, then again, it depends on the individual local hospital protocol. Some hospital, they use a modified Bromage score. It's more detailed. It's up to the 6 points. Okay, it depends. So we need to know what the local hospital protocol use. So this one, MOH Bromage score. Okay, so then we need to know also about the symptoms of the LA toxicity. So usually the symptoms usually is a central nervous system symptoms. Then finally patient develop cardiac arrest. So subjectivity usually lightheadedness, euphoria, and all that we need to detect earlier. Okay. So this is the AAGBI, the safety guideline. I think this one we already explained yesterday about this. Usually it comes with together this guideline, and then for the last management in our trolley, our LA or regional block trolley. How about the N6? Okay, N6 can be divided into the COX-1 or a non-selective. Is involved the COX-1 and COX-2, or COX-2 inhibitor. Okay, so this is a non-selective NSAID, diclofenac, ibuprofen, naproxen, ketoprofen, ketorolac, and meloxicam. So the danger of it is higher risk of develop cardiovascular side effect, MI, stroke, okay, upper GI bleed, and it's a nephrotoxic. How about the selective COX-2 inhibitor? Have a better profile compared to the non-selective COX inhibitor. However, use cautionly in a patient in ischemic heart disease. I will try to avoid the patient who has acute kidney injury or underlying chronic kidney disease, or with a recent stroke. Okay, so this is the NNT for the NSAIDs to be used to reduce by the 50% reduction of the maximal pain. As you can see, the ibuprofen and ketorolac is a quite good number here compared to the tramadol. Okay, yeah. So then again, I want to emphasize about the paracetamol dosing, especially for the patient in the pediatric or in the adult. So not all patients we need to use 15 mg per kg. So use cautionly for the patient who are a little bit underweight, about 10 to 33 kilogram. So because it's a 15 mg per kg, but the max dose is 2 gram per day. Okay, so need to be used cautionly for the patient who are underweight. Okay, especially patient who are coming, let's say in the hospital Queen 2, we have a patient coming for the esophagectomy. They're usually underweight and malnourished. Okay, so they are prone to develop, uh, you know, PCM toxicity. How about pain management in the ICU? All right, so pain management in the ICU always a challenge due to the sick patient, as patients are ventilated. Okay, so usually we can give by the continuous background pain infusion, or okay, due to the post-operative surgical incision or pre-existing pain. Okay, chronic pain arthritis, example in the RA patients, rheumatoid arthritis patient, neurological condition, Guillain-Barré symptoms, multiple sclerosis, phantom limb pain, also traumatic patients. Okay, also in the peri-procedural invasive procedure, central line, tracheal tube, NG tube insertion, CBDs, chest tube. Okay, and the routine care, positioning patients, tracheal suctioning, and even mobilization. Hence, I advise to our medical officer, please, when our nurse doing the physiotherapy, please provide a very good analgesia for the patient so that we can carry out all the physiotherapy that needed by the patient. Okay, so we want to assess the patient in our ICU. Let's say the patient is not intubated or able to communicate, okay, with a good GCS. So we can use our visual analog scale, or NRS, or VRS. Same as the patient we are using in the ward. How about the patient unable to communicate? So we use a behavior pain scale, or critical care or pain observation tool. Occasionally in our hospital, in our Queen 2 hospital, we use this CC port as a to assess pain. Okay, it has 4 components: facial expression, body movement, muscle tension, and compliance of the ventilator for the intubated patient. Okay, score 2 or more may indicate the pain. Okay, so you can see the C-port is a facial expression, body movement, muscle tension, compliant with the ventilation and focalization. Okay, it has a maximum point of 10. Okay, physiological parameters are not valid indicator. So when we do rounds, we cannot rate simply by the looking at the BP and heart rate high that it suggests of the pain. We have looked at the whole picture, and also better to use tool assessment tool, as example CPOT. Again, the self-reporting is a gold standard. However, CPOT doesn't measure the severity of pain. It just mentions that the patient has pain or no pain. Okay, we need to use also the monitoring, the interval monitoring at rest, during painful stimulation, before and at the peak of analgesic effect. The principle is we use the holistic multimodal balance analgesia, must emphasize on analgesia before sedation, and titration is the standard, and then individualized goals. And also we prefer analgesic sedation rather than the pseudo analgesia. Sedation means that we give the analgesia first rather than we started the sedation first for the patient, in which is proven reduce requirement of sedation, like reduce the mechanical ventilation durations, and reduce PTSD, post-traumatic stress disorder. So that's why when we do rounds, usually we have a sedation vacation, but we still continue our fentanyl or morphine infusion or ketamine infusion for the patient. How about the problem for the ICU patient in the pain management? Patient have a lot of problem because they have an ileus, they have an altered protein binding during acid-base balance. Okay, they have an altered splenic blood flow, organ dysfunction, worsening organ dysfunction, drug interaction, and pharmacodynamic effect. This is other example of the drugs that can be used in our ICU: fentanyl, morphine, ketamine, remifentanil, okay, and oxynome, tramadol. And this is another adjuvant drugs that can be used. Some patient, if you have a problem to manage the pain, okay, ketamine, clonidine, dexmedetomidine, gabapentin, pregabalin, and magnesium sulfate, and amitriptyline. Okay, so we can also use regional analgesia for the patient. Example, we use for the thoracotomy, thoracic epidural, paravertebral block. As example, for the rib fracture, sometimes I use for the paravertebral block or serrated spleen block for the patient who has a difficulty to control the pain in the rib fracture, especially those who are obese. Okay, or the limb fracture, example, hip fracture. So we can use fascia iliaca plain block for the patient who are elderly coming to emergency department with a hip fracture. Okay, so sometimes we provide the painkiller, thoracic epidural or paravertebral block for the acute pancreatitis. And also sometimes we provide the block, intercostal block for the chest drain. Okay, so with that, thank you very much. That's all for my presentation for the day.